Good afternoon, everyone, and I thank Dr. Mehul Shah for involving me in this prestigious IC. So, the 6-month incidence of developing post-traumatic glaucoma in closed globe injuries is almost about 3.4%. And how it is different from regular glaucomas, one is that it's unpredictable, the pressures are very high, not amenable to medical management many times, and the patients are much younger. So this is the difference between traumatic glaucomas and regular glaucomas. So the IOP rise in any case of traumatic glaucoma, we can say it can be acute, which is short-lived, acute unrelenting. Pressures don't go beyond 50 no matter what you do. Chronic, the acute phase goes into a chronic phase, but maybe at a lower IOP, and a late onset glaucoma. So you can divide it into these 4 categories. And the acute rise could be without, I have divided into 2, with hyphema and without hyphema. So it could be, the causes could be just the trauma, that is disruption of the trabecular meshwork. Angle recession is an indication of disruption, and immediately it will not cause high IOP. But because it's been disrupted, the TM, the IOP will rise. Inflammatory debris, if there is a lot of inflammation, it will block the TM. Iris pigment, yes. Lens particles, if the lens has ruptured, then the lens particles, vitreous normally 360 degrees is not going to block your trabecular meshwork, but it's an indication of how badly the injury has damaged the eye structures. So lens subluxation, it can block the angle because of various reasons. And trace hyphema. Sometimes you may find there may be a gap of 3-4 days before the patient presents to you, and you may find that there's no hyphema, but you put a gonioscope if the cornea allows you, and you'll realize that there is trace hyphema. And why I say it's important? Because it changes the approach to some extent, and even though you say it's a non-penetrating injury, you will be sometimes surprised to see a foreign body. So do a gonioscope, no matter how quiet the eye is. It will give you additional information. And then you have acute IOP rise, so in the acute phase with hyphema. So with hyphema, you may have all the other causes which are listed in the previous slide, but the RBCs, the bulk of the IOP rise is because of the RBCs blocking the trabecular meshwork. It is not very common in our country, but if a patient has sickle cell disease, then you cannot give carbonic anhydrase inhibitors, because they will, the RBCs will sickle and they will further block the trabecular meshwork. So here, what is the late onset glaucoma? So late, how late? It ranges from months to years. And let me spend a little more time on angle recession glaucoma. It's a very different kind of glaucoma. What is angle recession? I will not go into the mechanics of why it occurs, but it's basically because of the contusive, the force, there is a split in the longitudinal and the circular fibers of the ciliary body, and that is an indication of the damage, the amount of trauma the trabecular meshwork suffers, and that is angle recession. It is seen in after say few years, it is just seen as a wild, as a white broad band, and you will not realize unless you see carefully. If you see it after a few years, you have to be very, very careful to look for it. And typically the patient will come after unilateral, as a unilateral glaucoma, and you will try to find the cause, but that's when gonioscopy really helps, and a detailed history. The patient would have forgotten that I had an injury. And angle recession can occur years also. The second is a closure of, these are glaucomas which actually occur late after the trauma, closure of cyclodialysis cleft, that the pressure may be high, but because there is a cyclodialysis cleft, it acts as a treatment. It masks the elevated IOP. And this cyclodialysis cleft can close later at any time, and that is the time when the IOP will go high, and you will again label it as a late onset glaucoma. Again, it will be unilateral. History is of paramount importance. And of course, the surgeon or the ophthalmologist who had seen the patient first, if the patient had even gone to an eye doctor, should have done a gonioscopy. The other is, now these are over a few months, that phacomorphic, phacoanaphylactic lens subluxation which worsens can be a late onset glaucoma, but not years later, maybe a few months later. Retained IOFB, if you have not done a gonioscopy, even if you are saying that it is a closed globe injury, retained IOFBs have been seen, you know. and epithelial downgrowth. So that's not a very common cause, but this is just to complete the list. So what you have to know from all this is, the way you say, if you have had an injury, the retina examination has to be done once a year, year and a half, forever. Counseling for glaucoma is also for a long-term follow-up. The patients have to be counseled that no matter you're fine now, once you become better, every 1.5 years, you should come and get your eye examined. One more thing which I want to tell you about angle recession is that when it is late onset, many times don't forget to look at the other eye, because it is said that it's a person who is prone to primary open angle glaucoma will develop glaucoma if he has angle recession, and the other eye will also develop a POAG without any history of injury. So look at the other eye in case of angle recession when it is late onset. So treatment principles in general in the acute phases, that of course you assess the vision and the other anterior segment and posterior segment parameters, assess the IOP. Now the cause of elevated IOP, whatever it is, steroids, topical and oral form the mainstay of treatment, along with atropine and acetazolamide and IV mannitol. If there is corneal edema, assess the, put a gonioscope, assess the angle, and this can evaluation and fields later on when possible. Medical management, I have seen people are not very keen on using prostaglandins, but prostaglandins should be used. There is no contraindication. The only thing which you should not use is pilocarpine, and this is one exception. We always say step by step increase in the first use 1 drop, then add the other. No. In traumatic glaucoma, when the pressures are very high, you start everything at once except pilocarpine, including tablet Dimox. One more thing, of the optic nerve is healthy. So for a short time, if you are able to get the pressure down in the acute phase between 20 and 30, it's fine, because it can tolerate these IOPs for quite some time. And why I say with hyphema, without hyphema, even if you feel, most of the times conservative management of hyphema, waiting and using all the other things which I told earlier helps. But however, sometimes it's intractable, and even though you feel that the AC, there is not so much of hyphema, it still helps to do an AC wash. Debulking the anterior chamber really helps a lot in decreasing the load on the trabecular meshwork. So even if you find trace hyphema, please do it. Now here this is one person, after about 7 days the pressure just wouldn't come under control, and I had taken him up for AC wash. I had put pilocarpine, but because he was an atropine, the pilocarpine did not constrict the pupil completely. You have to be very gentle. You can't pull on the clots, because you may have a rebleed. Again, you keep on doing this for some time, because the liquid blood is hidden, so I don't know whether it is, and then you have to have an air tamponade. So sometimes the moment you take your cannula out, it keeps on bleeding again. So at one from how the retinal surgeons do a air fluid exchange. So you can just irrigate on one side and push air through the other side, so there is no fresh bleed. I know it is, I have exceeded my time. Can I have about half a minute, please? Yeah. So success rates of TRAB recently 88%, and success rate of tube in case medical management does not work, both work well. In my experience, if it is a younger patient and if it's a more severe injury, TRAB fails very fast, I would go in for a primary tube. But if it's an elderly patient, I would certainly do a trabeculectomy. And we don't have time for this. So the take-home message is that lifelong monitoring is necessary. And yes, if you find that the pressures are just not coming down, then you should intervene early, because the fields have gone from normal to tubular in 1 to 2 months. AC wash, if you find even little hyphema, do attempt it before you go in for TRAB or tube. Prostaglandins can be used very safely. Avoid pilocarpine. SLT has a limited role to play. TRABs and tubes work very well. TRABs, if the patient is older, yes, TRABs work very well. If the patient is younger, say between 10 to 20 or even younger, then tubes work very well. So thank you once again for a very patient listening, and thank you, Dr. Mehul, once again.
Thank you, Dr. Priti, for that extensive and very nice coverage of the subject of post-traumatic glaucoma. We have the panelists for this particular talk, Dr. Lipi Chakravarti, Dr. Amit Pandey, and Dr. Rinal Pandit. We'll request them to use the mic and discuss the aspects that they would like stressed.
Brilliant presentation as always, ma'am, and ma'am has covered almost everything. Just 2 points I would like to restate. Yeah, counseling of the patient when the patient comes to you. The departments also should know that if the patient has a blunt force trauma, they should refer it to a glaucoma specialist, even if the pressures at the initial stages are not very high. Because we need to counsel the patient, we need to see the angles. If angle recession is there, we need to counsel the patient that you have to have a follow-up, probably initially every 6 months and then later on at least every year, because glaucoma can happen at any stage, even many years down the line.
So on this subject, Dr. Priti, you mentioned about possible early drainage of the hyphema in some cases. Does it have a greater tendency for rebleeds in the post-drainage phase? Because that was one of the reasons why we were told to be more conservative. In some of the cases.
If the pressure does not come under control, the AC wash which I showed, no matter what I did, the pressure did not come down below 40. After about 6 to 7 days of conservative management also. So if you, with medical management, you are able to get the pressures between 20 and 30, then I would say wait and watch. But if it's not, then because of the same, the moment you remove the clot, there is a fresh bleed, if it's done early. So that's why only in intractable cases is what I say that you should go in for AC wash.
I have 2 points to make. One is measurement of intraocular pressure. So many of the comprehensive ophthalmologists, they ask me that how to measure pressure in case of a blunt trauma or even penetrating injury, whatever. So even digitally it can be done, we can have an idea. And if Goldman is not possible, then as rightly told, refer to a glaucoma specialist, tono pen, or there are other methods, DCT, dynamic contour, it's not available freely. So this can be used. And second, gonioscopy. It's not necessary that on the first go only you have to do, but successive days, 3rd day, 4th day, we can do it. And also I have a question to Dr. Priti. If there is rebleed, then how do you manage it? And ideally, hyphema drainage, like paracentesis, when it should be advised. Like that message should not go to audience, that even if there is grade 2 hyphema, grade 1 hyphema, we can go for paracentesis. Ideally, paracentesis, when it should be advised. And second, if there is rebleed, then what one should do. There's 8-ball hyphema, I washed it, second day, there is a rebleed on 4th day, then what should I do? 2 questions.
So the first question is, as I said earlier, that grade 2 hyphema, if the IOP is controlled, there's no corneal staining. You don't really need to do, and I'm not saying paracentesis, I'm saying AC wash. Only paracentesis and typically I tamponade with air whenever I do AC wash. So that is one thing. So AC wash, if medical management does not work, otherwise a trabecular meshwork in case of a small bleed will take care of the hyphema on its own. Second is, but if it's an 8-ball hyphema, typically the pressures go very high, but even then conservative management does work. So if the pressures do not come below 40 after say 3 to 4 days in an 8-ball hyphema and there is corneal staining, then you should take the patient up earlier. Again, there is always a chance that there will be a rebleed. So first is to counsel the patient, because otherwise the patient is going to say, kitni baar karne ka hai? So you have to say that we are trying to remove it because the pressure is high, there is a small thing, but tamponade it. And when you are retracting, if you see retinal surgeons do, when they do air fluid exchange, you remove the fluid and you put in gas. So similarly, instead of gas, we are using air. So you can use that, and the second time if you are taking the patient up, then yes, you should do that. But there have been cases where the rebleed does occur. But first is to counsel, and after the second time if there's a rebleed, I have not had a problem so far. But the possibility is always there.
That's exactly what I was going to tell you, Priti, because instead of doing, even if you do a paracentesis, and then you inject an air bubble. Instead of that, it is better to do a simultaneous one, where you position the patient's head, you go in, inject a little air, take it a little out. So it's a replacement
Yeah,
of
the air fluid
aerobic
exchange as
with-
what you all do.
Yes,
Yeah.
exactly. So it works better because it doesn't allow that hypotony to set in
Yes,
for a
yeah.
fresh bleed to occur.
So any role of
Tamponade.
aminocaproic acid which is
Sir, I
spoken
have never
about?
used it. It is mentioned in theory,
Yeah.
and there are very few surgeons who use it. But it can, in case of things like this where you have constant
Rebleeds,
rebleeds,
yeah.
you may use it. But I have never used it, sir.
Is it available and is it?
I don't even know about that, sir.
Okay.
Another one
Okay.
indication
So
which
it has
I
been used-
think you should also have added is traumatic endophthalmitis, because you get in penetrating traumas, you get traumatic endophthalmitis, and typically that causes a kind of a exudate all around the angle. So it causes a pressure rise. So even when we do surgeries, we have to go and literally strip off that area, otherwise the angles don't.
Don't.
I think in case of very clotted 8-ball hyphema, using irrigation and vitrectomy is very useful because it will strip out like exudates or clots, and at the end directly we start the air, continuous flow of air that will keep stopping, and that pressure we can control of the air. So it will cause the pressure hemostasis. And I just have a question, what is the role of vitamin C and K? Can you use that for to prevent the recurrent?
We do
You
give
can
it, but
use it.
how
You
much
can-
it works, typically when
no
a patient
evidence to say.
of
You can.
Evidence
hyphema
based.
comes, we give vitamin C.
Yeah.
So, but how much it really works, I don't know, but as a protocol, we do give it.
But there is no harm, I think.
Yeah,
there
there's
is
no
no
harm.
harm. Just I want to
No,
add
vitamin,
one, one point regarding Madam's question recurrent. If you think for recurrent, we can go for C3F8 also. If there is a patient is not prone, and my always I remove and immediately I just wait for moment. If there is a rebleed on the table, there is a tendency for recurrent bleeding. In such case, you can use a viscoelastics for 1 or 2 moment, high viscoelastic, and then aspirate, and then, but this is not a good one most of the time. But in such case,
I think
C3F8
we'll go
is
on to the next one because Akshay will miss his flight.